Hello, medical technology guys. Your Miss Merle is back for the discussion on the drugs of abuse. Before we will have RA 9165, the law that tackles about the criminal prohibitions and intensive law enforcement efforts to rid the country of illegal drugs. Let's talk first about the basics of the drugs of abuse. And let's have first amphetamines. It is a powerful stimulator of the CNS. It is used to treat some medical conditions, but it is also highly addictive with a history of abuse, followed by the anabolic steroids, commonly abused by athletes. The steroids are synthetic substances similar to the male sex hormone testosterone. And we also have the very common cannabinoids, which are naturally occurring compounds found in the cannabis sativa plant. Of over 480 different compounds present in the plant, only about 66 are termed cannabinoids, and the most well-known among these compounds is the delta-9 tetrahydrocannabinol. It's the main psychoactive ingredient in cannabis. It's the primary drug metabolite. Okay, and we also have opioids or opiates. So opiates are a class of drugs naturally found in the opium poppy plant, and that work in the brain to produce a variety of effects, including the relief of pain with many of these drugs. And opioids can be prescription medications, often referred to as painkillers, or they can be so-called the street drugs such as heroin. So that's for opiates or opioids. And we have cocaine from the erythrocylon coca plant. And please remember that cocaine is a highly addictive drug that ups your levels of alertness, attention, and energy. And you may hear it called a stimulant. So if you can see cocaine, think of the word stimulant. And we also have phencyclidine or PCP, commonly known as PCP, or phenylcyclohexylpiperidine. It is also known as angel dust, among other names. It is a dissociative hallucinogenic drug used for its mind-altering effects. So if you wanted to have the, depression and stimulation, and it's like a spectrum of feelings, so there's phencyclidine for that. And the next one is we have the sedative, the last one, sorry, the sedative hypnotics. It is a chemical substance used to reduce tension and anxiety and induce calm, or the sedative effect, or to induce sleep, hypnotic effect. And most such drugs exert a quieting or a calming effect at low doses and a sleep-inducing effect in larger doses. And sedative hypnotic drugs tend to depress the CNS. So they are CNS depressants for sedative hypnotics. So let's have the amphetamines. So amphetamine and methamphetamine are therapeutic drugs, yeah, and used for narcolepsy and ADHD. These drugs are stimulants with a high abuse potential. Sad to know that. They produce an initial sense of increased mental alertness, increased physical capacity with a perception of well-being. These initial effects are followed by restlessness, irritability, and possibly psychosis. And then abatement of these late effects is often countered with repeated use. So tolerance and psychological dependence develop with chronic use. And overdose, although rare in experienced users, results in hypertension, cardiac arrhythmias, convulsions, and possibly death. And various compounds chemically related to amphetamines are components of over-the-counter medications, including ephedrine, pseudoephedrine, and the one which is more familiar, we have phenylpropanolamine. And these amphetamine-like compounds are common in allergy and cold medications. And identification of amphetamine abuse involves analysis of urine for parent drugs. So we can use the urine of the patient as the sample for this. And then if you're looking for the parent drugs, and immunoassay systems are commonly used as a screening procedure. And because of variable cross-reactivity with other OTC medications or over-the-counter medications that contain amphetamine-like compounds, we have a positive result by immunoassay is considered presumptive. So how can we confirm? Confirmation of immunoassay positive test is most commonly made with liquid or gas chromatography. So again, if the thing you should remember with amphetamines, they are therapeutic drugs which are normally utilized to treat narcolepsy and ADHD. But they have this, again, as a review, they have this high abuse potential. And always think of, well, this can induce an increased mental and physical capacity, that feeling of increased mental and physical capacity. So somehow it will not make you tired. That's why people abuse this. But in higher doses, it can lead to restlessness, irritability, and there's a tendency that the patient will have psychosis. Next, we have the anabolic steroids. So they are a group of compounds related chemically to the male sex hormone testosterone. So think of the male sex hormone testosterone here. And these artificial substances were developed in the in 1930s as a therapy for male hypogonadism. So normally they are therapeutic drugs at first, and people tend to abuse them. And then it was soon discovered that the use of these compounds in healthy subjects increases muscle mass. So steroids increases muscle mass. And in many instances, this results in an improvement in athletic performance. That's why many athletes abuse these compounds. And a variety of both physical and psychological effects have been associated with steroid abuse. And chronic use of steroids has been associated with toxic hepatitis. That's why you have got the liver here. And chronic use has also been associated with accelerated atherosclerosis and abnormal aggregation of platelets, both of which predispose to stroke and myocardial infarction, or AMI, acute myocardial infarction. And in addition, steroid abuse causes an enlargement of the heart, And in this condition, the heart muscle cells develop faster than the associated vasculature. And this what's the problem with this? This may lead to ischemia of the heart muscle cells, which predisposes cardiac arrhythmias and possible sudden death. And in males, chronic steroid use is associated with, sadly, testicular atrophy and sterility and impotence. Take note again, chronic use, chronic abuse, especially in males. Anabolic steroids can cause sterility, impotence, and testicular atrophy. However, in females, the thing is it causes development of masculine traits, and there is the reduction of the breasts, and the same with males, there is sterility. We also have next the cannabinoids. So they are a group of psychoactive compounds found in marijuana, or the cannabis sativa plant. And of these, THC, or tetrahydrocannabinol, is the most potent and abundant compound present. Marijuana, or its processed product, hashish, can be smoked or ingested. And a sense of well-being and euphoria is the subjective effect of exposure. And it is also associated with impairment of short-term memory and intellectual function. Effects of chronic use have not been well established. However, overdose has not been associated with specific physiologic toxic outcomes. Tolerance and a mild dependence may develop with chronic use. And always remember that THC is a lipophilic substance. So lipophilic substance, so it tends to compartmentalize in the brain and the fat tissues, in the subcutaneous tissues. This results to how to say, in a slow elimination as a result of redistribution back into the circulation and subsequent hepatic metabolism. And the half-life of THC in the circulation is 1 day after a single use and 3 to 5 days in chronic heavy consumers. Again, half-life, if after a single use, is just a day. However, for chronic heavy consumers, it tends to the half-life is 3 to 5 days. And the hepatic metabolism of THC produces several products that are primarily eliminated in the urine. And then the major urinary metabolite is 11-nor tetrahydrocannabinol 9 carboxylic acid. This one, it's the major urinary metabolite. And this metabolite can be detected in the urine. It's just the same for 3 to 5 days after a single use, or up to 4 weeks in a chronic heavy consumer after abstinence. And immunoassay for THC, COOH, is the basis for the screening test for marijuana consumption. And GCMS, or gas chromatography mass spectrometry, is used for the confirmation. And both methods are sensitive and specific. And guys, remember, because of the low limit of detection of these methods, it is possible to find THC COOH in urine as a result of passive inhalation. So take note, even you were just able to passively inhale it, the result tends to become positive. And urinary concentration standards have been established that can discriminate between passive and direct inhalation. And this one, we have the erythrocylon coca plant, the plant which is responsible for, no, it's the source of the alkaloid salt cocaine. And cocaine is an effective local anesthetic with few adverse effects at therapeutic concentrations. So if we will use this as a therapeutic drug, cocaine is a local anesthetic. However, at higher circulating concentrations, it is a potent CNS stimulator that elicits a sense of excitement and euphoria again. Cocaine is an alkaloid salt that can be administered directly, like by insufflation or IV injection. So it can be injected or through insufflation, or inhaled as a vapor when smoked in the free base form crack. The crack is the free base form of cocaine. And also it has a high abuse potential. And what else? The half-life. The half-life, it has a brief half-life. Its half-life of the the half-life of the circulating cocaine is brief, like it's just a 0.5 to an hour. And acute cocaine toxicity is associated with arrhythmias, seizures, myocardial infarctions, and hypertension. And both subjective and toxic effects are expressed when circulating concentrations are rising. Because of its short half-life, maintaining the subjective effects over a single extended period requires repeated dosages of increasing quantity. Therefore, correlations between serum concentration and the subjective or toxic effects cannot be established. And because of the rate of change is more important than serum concentration, a primary factor that determines the toxicity of cocaine is the dose and the route of administration. Well, IV administration presents with the greatest hazard. So again, the greatest hazard is through IV administration, and closely followed by smoking. And cocaine's short half-life is a result of its rapid hepatic hydrolysis to inactive metabolites. And metabolism largely happens in the liver, and this one is rapidly hydrolyzed in the liver. And this is the major route of elimination for cocaine, and only a small portion of the parent drug can be found in the urine after an administered dose. The primary product of hepatic metabolism is benzoyl ecgonine, which is primarily eliminated in the urine. And then the half-life of benzoyl ecgonine is 4 to 7 hours. The presence of these metabolite in urine is a sensitive and specific indicator of cocaine use, and it can be detected in the urine for up to 3 days after a single use. And in chronic heavy users or abusers, it can be detected in urine for up to 20 days after the last dose. And the primary screening procedure for the identification of cocaine use is detection of benzoyl ecgonine in urine by immunoassay. And again, confirmatory testing is done by GCMS. Next, we have opiates. Well, opiates are from the opium poppy plant, or derived from the opium poppy plant, this one. They are a class of substances capable of analgesia. There's an analgesic effect, sedation or sedative, and anesthetic effects or anesthesia. And all are derived from or chemically related to substances derived from the, again, opium poppy plant. And the naturally occurring substances include, we have opium, and what else? Morphine and codeine. Again, naturally occurring substances under opiates, we have opium, morphine, and codeine. Heroin, hydromorphone, and oxycodone are chemically modified forms of the naturally occurring opiates. So if we're talking about the naturally occurring substances of opiates, we have the, again, opium, morphine, and codeine. But for those which are the chemically modified forms from the naturally occurring opiates, we have hydromorphone, oxycodone. We also have meperidine, methadone, and propoxyphene, and what else? Pentazocine and fentanyl. They are common synthetic opiates. And guys, remember, opiates also have a high abuse potential. Chronic use leads to tolerance with physical and psychological dependence. Acute overdose presents with respiratory acidosis, and this is due to the depression of respiratory centers. There is the presence of myoglobinuria. There is myoglobin in the urine, and possibly an increase in serum indicators of cardiac damage like the creatine kinase, MB, and troponin. High-level opiate overdose may lead to death. So just don't overdose. I'm just kidding. And it's caused by the cardiopulmonary failure. Treatment of overdose includes the use of opiate antagonist naloxone. So what is this opiate antagonist? We have naloxone or Narcan. That's the naloxone is a generic name, Narcan is the brand name. And then what else? Laboratory testing for opiates usually involves initial detection by immunoassays, the screening, and most immunoassays are primarily designed to detect morphine and codeine. However, cross-reactivity as a result of similarities in chemical structure allows detection of many of the opiates, and naturally occurring, chemically modified, and synthetic. And again, GCMS is the confirmatory method of choice. And now we have this one known as the, we have this stimulant depressant drug, an illicit drug that gives you stimulatory and depressant effects, and anesthesia or anesthetic effects, and hallucinogenic properties. Like, it's really a spectrum of feelings here with phencyclidine or PCP. And adverse effects are commonly noted at doses that produce the desired subjective effects, such as there is agitation, hostility, and paranoia. Overdose is associated with stupor and coma, and PCP can be ingested or inhaled by smoking a PCP-laced tobacco. It is a lipophilic drug, and it easily or penetrates the brain and the adipocytes or the adipose tissues. Elimination is low since it is lipophilic. This is a result of the redistribution into the circulation and hepatic metabolism, and about 10 to 15% of an administered dose is eliminated and changed in the urine. Hepatic metabolism forms various products, and identification of PCP abuse is by detection of the parent drug in the urine. And in heavy chronic users, PCP can be detected 7 to 30 days after abstinence. Quite long, it's quite long, 7 to 30 days after abstinence. And immunoassay is used as a screening procedure. GCMS is the confirmatory method. So that's for phencyclidine. And lastly, we have the sedative or sedative hypnotics, and many therapeutic drugs can be classified as sedatives, hypnotics, or tranquilizers. And all members of this class are CNS depressants. So there's depression, there's tranquility. Think of sedative, hypnotics, and they have this wide range of therapeutic roles and are commonly used. And most of these drugs have high abuse potentials, ranging from high to low, sorry. And these drugs become available for illegal use through diversion from approved sources. And barbiturates and benzodiazepines. So barbiturates and benzodiazepines are the most common type of sedative hypnotics abused. Although barbiturates have a higher abuse potential, benzodiazepines are more commonly found in abuse and overdose situations. And this appears to be a result of availability because benzodiazepines are more available as compared to barbiturates. And there are many individual drugs within the barbiturate and benzodiazepine classification. We have secobarbital, we have the phenobarbital classification, and pentobarbital, which are more commonly abused barbiturates. And we also have lorazepam and diazepam. Lorazepam and diazepam, which are the commonly abused benzodiazepines. And then what else? Overdose with the sedative hypnotics initially presents with lethargy, like they love to sleep, very sleepy. And there is the presence of what else? Slurred speech, which can really progress to coma. And respiratory depression is the most serious toxic effect of most of these agents. Again, respiratory depression. And hypotension can also happen with barbiturates. And the toxicity of the many of these agents is potentiated by ethanol. So it's not good if you take alcohol too. And immunoassay is the most common screening procedure for barbiturates and benzodiazepines. And again, as the same with other drugs of abuse, there's this broad cross-reactivity with members of each group, which allows for detection of many individual drugs. And GC or liquid chromatography can be used for the confirmatory testing. And that's the end of this very brief discussion about the drugs of abuse. Thank you and goodbye.